This conference will now be recorded.
I want to thank you guys for taking the time to join us today. We've got a whole bunch of stuff to discuss in an hour, so we're going to try to keep it moving along. But if we can, real quick, if we can just see who we have on the phone. I'm just going to kind of mention your name, and if you're there, just give me a howdy. Alan Patterson.
Howdy.
Right. Okay, Henry Taylor. No, I know Vicky, you're on for him, so I know you're waiting for him to come in the room, but that's okay. Alan Cintron.
Yes.
Okay.
Dr. Garcia.
Okay, great.
Okay, yeah. And Joe Fuentes. Joe Fuentes, okay.
Okay, Wayne Rowe.
Veronica Clark.
Here. Good morning.
Morning.
Okay. And do we have anybody else on the line?
This is Locke and Tammy from Tri-City Health Center.
Okay.
Excellent, thank
Okay,
you.
great, excellent. Thanks for joining us. Okay, well, very good.
And hi, this is Henry Taylor. Hi, this is Henry Taylor from Chicago
Henry.
Mild Center.
Glad you're with us.
Thank you, sir.
Okay.
Hi, this is Allie Dubois from Hudson River Healthcare.
Oh, Allie, thanks for joining us. Really appreciate it. And we're going to just try in the next hour to cover some fairly big issues. And so we're going to deal with some issues we discussed at the Council on Special Populations meeting and at the Public Housing Task Force meeting at NAC-PNI back in March on kind of transformation of public housing. We're also going to talk about the Public Housing National Event. And then Dr. Saki Cho, our Director of Research, is going to run us through some needs assessment related discussion. And partially it's going to be issues that were found in the National Needs Assessment that the NRC did about the needs of health centers relative to training and technical assistance. And then we have some specific questions we're hoping to get feedback from you guys on during the call. So the first issue we're going to talk about quickly is the transformation of public housing. And I think most of you folks, it's really no surprise that there have been significant changes in public housing over the last 30 years. The advent of tenant-based vouchers has kind of changed the game a little bit. No longer do we have centralized developments only. There have been a number of programs moving to work, RAD, multifamily developments through Hope 6 and Choice Neighborhoods have just kind of changed the way people look at public housing. And also it may change or may have changed the way we need to work with housing agencies and housing organizations to partner and deliver healthcare and social services. We discussed this a little bit at the NAC-PNI meeting back in March. And one area we really didn't get into very heavily is the impact that those changes may have had or are having on the way we work with other folks. So we'd like to have a little discussion on that. But just for a little background for the folks who did not attend the PNI meeting, right now there are slightly under 2 million units of traditional public housing. HUD has gone ahead and approved the conversion of about 400,000 of those units to RAD, which is the Rental Assistance Demonstration Project. And in that, basically, those units are converted by either a private developer or a nonprofit, which may be in part controlled by the housing agency, which allows them to borrow money, which allows them to leverage housing assistance payments to do renovation, and renovations are badly needed. HUD estimates at a minimum public housing needs about 26 billion in repairs. Others folks at NARO and other housing organizations have estimated that number may be upwards truly more between 40 and 60 billion. So there's a lot of work. Over the last 30 years, Congress has chosen not to really fund capital expenditures. The HUD budget again this year has zeroed out the capital funding. Now they've also done that the previous 2 years, and Congress always puts that money back in, but it's minimal. It's not enough really to keep up with the need. And so in order to find a way to really reinvigorate the housing stock for affordable housing, housing agencies around the country have chosen to go RAD, if they can make it work. And our question, I guess, our issue is how is that going to impact our residents, and what kind of services, resident services, will be provided to those folks once they make that conversion. Some of it's been done through family self-sufficiency coordinators, which coordinates various services, including health, including education, job search, job training, enabling services like daycare and transportation. So there are some questions out there as to how this is going to impact us all in the future. And I guess, and I don't, and the question, and Ali, I don't know if you want to, I'm sorry.
No, I'm just going to say, Bob, that basically the conversation started because we were invited to participate. We went to HRSA, participate in the Special Pops, Council on Special Populations. This is something that Jim McCray brought up, specifically when they realized that the numbers of those, the reporting of those patients being served in community health centers in or immediately accessible to public housing, the number is 3.5 million. He said that the numbers didn't make any sense since we only had 2.2 or less than 2 million people living in public housing. So this is something that HRSA wanted to know what is happening in public housing, what changes are happening. And this is they said that probably, and this is probably next year or in the upcoming years, they are going to switch again and the way that we are counting public housing residents. So that's the origin of this conversation with HRSA.
Right, and so there's the counting issue, which we have to deal with in UDS. And I think at the P&I meeting, I think it was the will of the group that we would kind of table that issue while people thought about it a little bit. And HRSA has not really pressed us on it, so there's nothing urgent. So we can discuss that a little bit if you like. But I also would like to discuss the issue of how these changes may be impacting the health centers that are out there. Now, if you're in a traditional public housing setting, maybe there really has not been a significant impact. But where in the past, you dealt, straight on with the resident services director at the housing agency, it may change a little bit if they're in RAD developments, and those folks are no longer in properties controlled, by the housing agency. So I would like to just get a little feedback on that topic, if it's possible, from the folks on the phone. And if anybody has a thought, or if anybody has really seen any significant changes on their end. So Ali, do you have anything up in Hudson River? Have there been many changes with some of the changes in public housing, or is it something that's not been a big impact in your area?
It hasn't been a big impact in our area yet. I think it was the discussion we had when we were together was really, I think, one that was forward thinking, right, around reporting.
Yep.
And the guidance, and that as this trend continues, there will be fewer people in traditional public housing, which is the way that the that the statute is written,
Yep.
And so it's challenging to think about, how do we articulate the needs of residents of public housing when some of those challenges are exacerbated by the dense nature of historic public housing, which is no longer going to be the predominant way that public housing looks. So it's a challenging thing, right? We fought very hard to say, don't change the UDS reporting, because right now it is, we historically had a way of capturing, and we still ask every patient, about their status as a resident of public housing. But the UDS guidance, has us reporting all patients in proximity, so that's a full health center instead of, based on the self-reporting. So now to unwind that and to go back to reporting specifically based on, address matching and patient reporting, is going to create dramatic shifts in the way that this information is looked at, but also potentially undermines the intent. I find it very challenging to think about how to unwind this.
Yep.
But to your specific question, we have not experienced, our public housing buildings have been relatively stable. So there haven't been any changes that have come forward.
Okay, all right, that's fair enough. And relative to the issue of counting UDS, Alan, when we had the discussion at P&I, you referenced the fact that you and some other health centers were, you were counting the way it's described on page 46, which is basically, if you have, patients, or if you're interaccessible to, you count everybody who goes to the health center that's interaccessible. But you also referenced the fact that in another section of UDS reporting, you were counting a more, actually a more traditional way, either with address matching or with, asking the patient. So Alan Patterson, can you comment on that?
Well, yeah, I think that's exactly right. But just listening to Ali there, I see where people are having a tremendous amount of confusion. Yes, we have a site that is smack dab on one of the public housing complexes. It's probably, 3/4 of a mile, maybe a mile as the crow flies from our main site. And that particular site is a very busy site. We're busy at the main site, so that particular site gets a lot of overflow from the main site. And it's a busy site. But the main site, while it's not smack dab on a public housing complex, it would take me less than 3 minutes to walk over to another public housing complex. And if I stand on the side of the main site and look down the road, I could see at least some of the units of the public housing, of a separate public housing complex. So we're only using, that site for the main count, the unduplicated patients and, whatever it is, schedule 5 or, 3, 4, and 5. Now, so we're only using the one location that is smack dab on the campus of a public housing complex. And it, we haven't expanded that to include the main site patients, which would dramatically increase our counts for public housing primary care. But yeah, then when it comes to doing the detail work, I think on the diagnosis and select services, then we're actually dropping it down as we interpret the instructions to say to those that are actually residents of public housing. The overall discussion, though, I don't know that it's, and this is what HRSA has said for us to do in terms of the count. And while I didn't particularly care for the change, I'm not sure I'm the one that would be in a position to argue with them about what they feel is is the right way to report it. I do see that it's probably better to be inclusive. If we're going to be including everybody that is proximate to any one of our sites, I'm not sure it's that big of a leap to start including Section 8 and everybody else. I really don't know what the right answer is, but I do think that we've got to be attuned to the changing definition of public housing.
Yep. Well, I think what the the definition says now that you can't count those who receive housing choice voucher only and without any other support. And I think what's up for grabs or discussion with HRSA and whoever else would be interested is whether or not, if they provide other supports, say through an FSS, a family self-sufficiency coordinator, if that counts as support. And if it does, then that may help avoid I guess a difficult discussion. But I think it remains to be seen, how they would interpret that. And again, I want to just say, because I think people were very concerned, I think, at the P&I task force meeting about this. HRSA brought it up, and they did raise it, and they did say, there was a possibility of changing the way that we're counting. They said, basically, it probably wouldn't happen until 2020, or 2021. So it's not going to happen tomorrow, but I think it's just something we have to kind of think about and prepare for, and think about how we want, I guess, to best represent, the population that we're serving, and the health centers involved, and kind of make those. I mean, we can't individually or collectively tell HRSA what to do, but we can make suggestions, and they are willing to listen. So I think we just need to come up with what we think is the best solution, and kind of work toward that, over the next few months. And I'm sure we'll be able to tackle this again at CHI. But I am kind of interested because Allie's point earlier about the fact that she's not really seeing many changes at Hudson River. And I think, and I'm just curious if other folks are seeing any significant changes with, RAD developments and moving to work, or choice neighborhood, multifamily developments, or has it pretty much been, status quo for everybody?
Well, Bob, I had told you that, I'm going to come back to a question that I wanted to ask you, but I had told you last time we spoke that, no, I really haven't seen much change. But since that time, we have our main site. We're based out of Wichita Falls, Texas, which is about 145 miles northwest of Dallas.
Mm-hmm.
Then we have a relatively new site that is 30 miles north of Dallas, 25, 30 miles north. It's called McKinney, Texas. And just literally just right after I spoke with you, I'm driving down one of the roads there in McKinney, and the entire public housing complex has been raised. So my antenna has gone up. I really don't know other than what they're doing, other than I've heard that they are replacing the public housing units. And I don't know the specifics yet. So, I'm going to kind of withdraw, well, no change, because obviously something significant has changed. This was not a small public housing complex. It was a pretty good size one for Texas anyway. So I have seen some changes. I did want to jump back, and maybe we do this now or later, or maybe we can do it offline.
Sure.
Seems to me that HRSA is the one that's redefined this count process. I don't remember getting up in arms or getting in their face about it, and they changed it. And that's fine. We're all trying to abide by the rules. But why are they concerned now? What's happened that all of a sudden they're concerned about the new rules that they put in place?
Well, you know what, Al, I think partially it's the fact that, when they implemented the new rule, initially everybody was not probably following it to the letter, and some people still aren't, obviously. And so over the last couple of years, the number has grown significantly as more and more people have adopted the reporting requirement. And so, right now, as Jose said, when that number was coming up as 2 million or 1.17 or whatever it was the first time around, well, it seemed kind of reasonable. And now I think the issue is that, right now I think it's a 3.7 at the latest UDS number. And then you run that up against the fact that the number of, public housing units is down. The number of people in public housing is down around, a little less than 2 million right now. And it's like, wait a second, so I think a lot of people made some assumptions when they saw that number. The term that they used on their reporting is publicly housed or something they use on their slide. And initially, as I said, that number was kind of in keeping with the number of people who live in public housing. But now it's not double, but it's getting close. And I wouldn't be surprised if, the next go around, if that number doesn't go up again. And I think really that's probably what's got them a little bit,
Spooked, sure. Okay.
So I think it's kind of understandable. But any other feedback from folks as to whether or not they are actually seeing changes? Alan Cintron, or
This is Veronica. We haven't seen there's any changes of such, but I'm sure they're going on. I'm going to our local community advisory meeting today right after this meeting, so I'll find out from them if there's anything that I need to know. Our housing, projects remain intact, but ours, as you know, was these weren't high rise. These are like townhome units, stretch over 17 blocks. They still continue to do renovations. They're still putting in state-of-the-art library. They're still, so I'm sure there are going to be some changes, and maybe they're just doing this for now. We hear that they're going to change the units to mixed income. Then some people dispute that, but we're not sure. In Chicago, they're extending. We know the Red Line. There's a train that stops at our major hub at 95th Street. They're extending it down to 130th Street, where the housing projects, where the community housing project is. So we know that's going to create, that in itself is going to create some change. We're not sure what it is. And I think people have been given mixed messages.
Okay. Anybody else?
In Puerto Rico, we have not experienced any changes in the administration of the public housing. But however, there is a decrease in population in the public housing due to Maria, the Hurricane Maria. Many people moved to the mainland, to the United States. So that's why it's the only change that we have reported.
Okay, that makes sense. Yep. Okay, very good. So regarding the issue, and again, I think we want to proceed with caution as much as we can. What we're going to try to do, and we've begun the process, is to try to confirm with HUD, as to what they really plan to do long term. Now, right now, I mentioned before that they've allocated the conversion of up to, I think, 400,000 or so units of public housing. Now, that's not something that's going to happen, in a day or a year. But it's obviously that, that they are going to make some more changes. So that would definitely impact the number, and it's a significant change. But part of our concern is, are they going to provide the level of resident services and assistance that they do to public housing residents? And kind of that's really our first order of business. And then really to kind of see how that would bump up against the definition, and whether or not those folks would still qualify under the PHBC number. And then I think if whatever the case, I mean, we have to make sure we look out for the residents themselves, because if somebody moves into a RAD development, they're going from a traditional public housing, development, which may be a renovation of that very same development. So they're going to be still living in a fairly densely populated area with other folks, with the same, same socioeconomic status and issues and the like. And the vouchers that they received are project-based, so they're tied to the unit. They don't go with the person, and they're not tenant-based. They're not like a housing choice voucher, and so they have those same issues. So the question remains whether or not they are going to provide that level of support, the coordination and so on and so forth. Because, and also, for example, if we reached out, we said we want to make sure that the residents of XYZ RAD development, have health care, would we be able to reach out to those people through the housing authority, or is the housing authority going to say, well, no, we need to put you in touch with the developing entity, who's now, running that housing? And I think it's just some things that we need to clarify and then work out, and then maybe kind of develop a strategy as to how we want to, address handling those changes and making sure that we do get care out to folks. So does anybody else want to make a point on this topic? Okay. We will report, like, on the next call in about 2 months, kind of what's up and if there are any significant changes, which I don't really anticipate anything too significant, but we're going to try to reach out and try to get some information from HUD itself. Okay. I think the next major issue, the needs assessment's up on the screen, but I think we're going to talk about the conference first.
Yes.
Okay. So we're trying to plan a national training symposium or conference, and there are really two big issues, or two or three big issues. One is kind of when, the other is where, and then the third is the format. And we have done, kind of traditional conferences in the past, covering, a variety of issues, some of them dealing with clinical issues, some of them dealing with workforce issues, some of them dealing with, SDOH and special and vulnerable pop related issues. We were wondering if, at this time, and this is somewhat related to the changes in public housing, do we want to add a component to this, which will be kind of more of a working session, if you will, where we might do something with, some breakout sessions where we have and facilitated working sessions where we're trying to really get at the heart of any needs or of some kind of identification of best practices or development of best practices, and some of which may be around the changes in public housing. And in doing so, would you guys be supportive of doing something where we would bring in people from public housing for those sessions, and maybe social services, agencies or entities as well, to kind of participate in a working session where, again, we might be able to provide clarification of needs, development of maybe either a plan to put together best practices if we can't find them. So do we just find best practices? Do we find and modify and develop? And there are a number of issues that we've discerned, from the needs assessment, which Saki will talk a little bit about in a minute. But we can certainly get into any of the managerial or clinical issues, and collaboration issues, I guess, are of concern, because one thing we're seeing is that when we've surveyed over the last few years, the number of folks who have a formal arrangement or working relationship with the housing authority has actually been decreasing. And we want to work on building that up again, but we don't know if there are greater issues, and some of them may be associated with some of these changes in public housing. So if we could start with that issue, you know, I'd like to. And so if anybody has a thought or a comment on that. I know you guys aren't bashful. Let's see, who hasn't? Henry, you out there?
Here, Bob.
Do you have any thoughts on that?
Well, I think it's kind of hard to do best practices in one day. You know, I think maybe best to get some pre-work done if you're going to do best practices, or see what's out there and what's been modified just in response to that particular issue. I like the idea of breakout sessions, but I was really waiting to hear from the group and how they respond to that. I like the idea of bringing in, you know, the housing and social service issue piece to sort of provide a broader perspective of just how we provide the entire wraparound service. But I want to see what the group has to say about some of these issues as well.
Sure. Okay. Allie, do you have any thoughts?
Which Alan, or does it matter? The other Alan probably has more informed thoughts than this one does. So, you know, I think that, you know, the previous comments are great. I guess that this whole discussion about who do we count and who do we not count, maybe some guidance on how we can best serve the changing face of public housing, you know, whether that's, you know, quality measures or access measures, just some good guidance on how do we adjust to this uncertain definition of public housing residents, and do the best we can given that uncertainty.
Okay. All right.
I just don't want to get in trouble, you know. I mean, I hate to put it this way. I want to do everything I can to increase access to and reduce the disparities in the provision of primary healthcare services. I know that's what all of us are trying to do. Certainly the ones that are on this phone call, but oh my gosh, you know, I mean, it would kill me. It would crush me to be doing the best I can do and find out I've been doing it wrong, you know, after the fact. And so I really would like to be able to feel good that I'm not going to come in and get slapped down for doing the best I could do given the uncertainty of the definitions.
Well,
part of it is just the idea that, you know, knowing that the conversation about the count, I think, Bob, you started off by saying that the feds really want to sort of put this on hold to give further thoughts to it. I know, so I think that's sage advice, just to hold off on that until we get further dialogue from the Bureau, because I think part of it is the count either way was always a challenge, no matter how we did it. You know, we couldn't get an accurate count of patients who live because of address and data systems. So I think the Bureau recognizes that right now we just don't have an ideal process in place. I do believe, however, there are some basics that are still exist today as it relates to public housing. I think the proximate issue is one side of it, but the issue that at least from my desk, that needs to stay in front of us is the basic facts of this population have worse health outcomes than our primary care group, and what we should be doing to sort of mitigate that. I think it's one of those basic things that should stay in front of us, no matter what the definition is, and how, as we have this definition, how we're dealing with these separate groups. Those are approximate to, and then what are we doing for those who are really living in public housing, and as the environment change, what are the things we need to do to adjust to that changing environment in terms of our services for this changing population? And as you describe, as you look at this private funding that may well come through and change some of the housing format, really what does that mean for us? I think it would be worthwhile to sort of strategize, to have a more of a, strategic thinking process to sort of lay out some broad stroke strategies for how we respond to some of these issues. But clearly for me, staying in front of us, that there's still high incidence of, mortality, morbidity, and hypertension, diabetes, well beyond what we see in the private sector. So in our other population. So.
Gotcha. Allison?
When I think about the conference, I think some of the opportunities would also be to think about how some of the key issues in health centers in general may have a different face or being addressed innovatively, population. How are we engaging with veterans, and what's the work that's happening with veterans in public housing? What's happening with the opioid epidemic? What does that look like in public housing? Is it different? Is there anything we can learn about that? What's happening with the rising rates of suicide? New York just completed a study, and higher rates among veterans, Latina adolescents, in the LGBT community. Is there anything in particular? Sometimes it may be as it relates to residents of public housing, but these are important issues for all of our populations, and innovative programming in these settings or that have been shown to reach folks, especially as we have found it more and more difficult, to get our patients of all types to participate in groups or in other types of activities. Those would be topics I would find interesting.
Okay.
That's great.
Very good. All right. Well, we are actually trying to, have been working with a group of how to facilitate this thing. And I guess some of our general thoughts have been that what we might start off with would be the first day would be a kickoff and probably somebody from HRSA and somebody from HUD, especially from HUD, kind of giving an overview on the public housing issues, and then from HRSA on the housing and health issues. And then maybe at some point, and we're trying to figure out the optimal time to do that, do some kind of, a working session, maybe a couple of sessions, dealing with, I think, some of the things that you're talking about, kind of to get at strategies for dealing with some of the changes in housing. And we can also incorporate within that those things that are those issues that are also have great relevance to the public housing population. And Allie just talked about vets and opioids and suicide, and of course violence across the board, in addition to the traditional chronic disease issues that we've been dealing with for a long time. So I think we will proceed on that path. I guess if I would look for a little feedback from you guys. How much time do you think is reasonable? What portion of time do you think is reasonable to put into during the event on changes in public housing versus everything else? I mean, we were thinking maybe about a half day on that, and I don't know how that sounds to you guys.
That seems like a lot.
Too much?
I mean, I guess the question is there really that much? Does it need to be, reviewed in that much detail? I think if there's a way, or if there are speakers, or if there's a perspective, or if you're including, some other trends, I think it's important for people to understand it and to do that well, but whether that's a very extensive plenary that you're proposing that has multiple speakers on the topic, I would just be sure that you could lose folks. That's pretty dense. Yeah.
I mean, I'm really talking about more the portion that would be about getting people in the kind of a facilitated environment to get their feedback on, on what they're experiencing or how might they, or the changes might be addressing them. I mean, I spoke to somebody in Fort Worth, Alan, in your neck of the woods a couple of weeks ago, and we were talking about some of the work that they were doing, what they're going to do with the health center in the area there. And her comment was, things are really moving along well, but, her concern was that she's Ross funded through HUD, and she didn't know if she'd be there in 3 years because of, some of those changes. And I think that's an extreme case, but I just feel like we need to try to get ahead of this thing. And I'm just trying to, and I think we're all trying to figure out a way to do that in a way that makes sense. But at the same time, to Allie's point, we don't want to provide an event that people don't want. And so we're trying to find, I guess, the right balance, for that. So any other feedback on that? Okay, well, here's a couple of questions, or a couple of points. Basically, we have kind of right now we're thinking about 3 different options for the event or the timing of the event, and the thought is kind of an accelerated would be to do something in piggyback with CHI in August, and the other alternatives would be October or November. And in terms of location, well, obviously CHI is in San Diego. I believe it's San Diego.
Chicago.
In Chicago, I'm sorry. In my head. PCA is in San Diego. And then the alternative we would probably do we were thinking DC probably in October or November. So any feedback on that?
I mean, you're talking about a half a day, though.
No, I think we were talking about doing about a day and a half.
Day and a half, okay.
Yeah.
Because it'd be unlikely for me to make a separate trip for a day and a half, or excuse me, for a half a day.
I think last time we discussed this, we said we would do it in combination with, say, one of the CHI conferences to get more people there.
Yeah.
And you would do it like a day before or a day after or something like that.
Right. Yep. And that was the thought of maybe doing CHI. We just didn't know if it's too quick for people to plan.
Well, I guess it kind of depends. I mean, I've bought my flights for CHI. I don't know if everybody else has. I'm usually way ahead of the curve on that kind of stuff. So, if I could, I would. For whatever date y'all put, if I can do it, I will. So.
Yeah, I think our thought was if we did CHI in August, we would try to do something the day, the Thursday. And so the full day would be Thursday, I think the 15th, and then the half day would be the 16th on the Friday, because the committee meetings start on Friday afternoon, and the conference actually starts, I believe, on Sunday.
I think tying it to the CHI is our best hope for maximum participation. I think the timing on it and how it overlaps with other expenses should be reviewed. So you're saying Thursday and half a day Friday, and committee meetings Friday. I think it's consistent with other.
In fact, the public housing committee meeting is at 1:30.
Right. Great.
On which day?
That's Friday the 16th. I believe it's the 16th of August. Yeah.
Hey, Bob, you're saying the CHI is in San Diego, or are you saying?
No, I'm sorry, Henry. It's in Chicago, and
it's in Chicago.
You and Veronica probably very upset at me, but
yeah, it's in Chicago. Just as
I know. Yeah, it's the PCA CCN is in San Diego.
All right.
My brain is very addled, so. Any other thoughts?
Yeah, I mean, that 15th and the 16th, for whatever reason, I'm flying in on the 14th, so I must have been anticipating this. So,
Well, I hope it doesn't mean there's something else that's some other knack thing that we're not aware of. We did check it, but maybe we should double verify that we're
no,
not.
I think I purposely set myself to come in early just in case you all did this, or I'd take off and do
Okay.
some sightseeing or whatever for a day or two. But so either way, that works.
Okay, so folks think that that August is still viable. All right. Well, all right. We'll push ahead. And guys, at this point, I'm going to turn it over to Dr. Saki Cho, our eminent director of research, and she's going to kind of go through some needs assessment results and ask you guys a few questions. So go ahead, Saki.
Hi, everybody. Jose, can you switch slides?
Sure.
Change slides. Thank you. Okay, so as Bob and Jose mentioned, we just briefly want to go over some of the results from the National Health Center Needs Assessment, and just a brief reminder. This is a survey that all of the NCAs worked together to develop to provide kind of a consolidated way of reaching out to health centers so that health centers would only be asked to fill out one needs assessment versus like the multiple times different NCAs were asking them. So it was fielded last September to October, and around 1,400 health centers responded. 56 of them were PHPCs, so that's about a 56% response rate for both all health centers and also for PHPCs. And the two major objectives of the survey was to find out what the current pressing TTA needs of the health centers are and what ways the NCA's TTA could be improved in the satisfaction of the TTA that was being provided. So can you switch slides, Jose?
Oh.
So at the health centers received a list of, I think it's 9 different topics, and they were asked to rank the issues in order of importance. And so you can see here, 1, 2, 3, 4, 5, 6, 7, 8. These are the different issues that the top 3 that health centers mentioned. This is clinical issues being number 1, value-based healthcare transformation number 2, and then the third as workforce. Now, the PHPCs did respond a little bit differently. They said their primary topic issue was value-based healthcare, but again, it was still the top 3 were clinical, value-based healthcare, and workforce issues. And so my first question to you all is, do you agree with these findings? Are these the top 3 issues that you would choose from this list? And if not, what topics do you think are the priority? So I'd like to hear your feedback based on what you see. And I think this will help us, develop the agenda for our in-person meeting that Bob was just talking about.
I don't know that I disagree with, the issues of it. It's a little bit different for me. I would have had a different order on those. But then again, I'm in a state that is the poster child for not expanding Medicaid. So finance is a huge issue for us. If you're in a state that's expanded Medicaid, you may very well be doing better financially than we are. So I would say, it's a little bit different order than I would have expected, but it doesn't surprise me given that 33 or so or 34 states have expanded Medicaid and we're in one that's not.
These are just incredibly broad topic areas. So, I
don't think that there's anything fundamentally to disagree with. It's and they come in so close in terms of the overall number. So I don't think that there's anything off about them. I think that they are all, sort of the key pieces here. Which clinical issues, would be important to understand.
Yeah, so that's a great point. I guess our next question is, what aspect of clinical quality or behavioral health or whatever do you all think is most challenging and would need TTA on? What aspect of the workforce building and development, and what aspect of value-based healthcare would you like to see specifically addressed with our TTA that we provide, but maybe also at the conference?
I mean, I think I mentioned some earlier. So those, I think, remain important priorities. I think others, certainly always mention innovative strategies on addressing chronic conditions. Certainly I'm speaking to the clinical area. Value-based contracts, it's really hard to think about what you would offer in a conference-like setting that's not, a value-based conference setting. And these would be broader concepts because I'm not sure that any of us, have a particular contract or an approach to this that is population specific, usually payer specific. So, this is, this is skill development that has a broad piece of it. Components of where and how social determinants have been used to, risk stratify. And whether it's interesting, most of the risk stratification that we've seen doesn't include public housing status as a driver of greater complexity, but rather homelessness. So the fact that someone has received or has stable public housing is actually would potentially lower the risk calculation. So that it's an interesting kind of interrelationship there around the social determinants piece and how that impacts and thinks about how you would do the risk stratification, to focus on performing under value-based contracts. So, it's a hard concept to think about how it applies with a specific public housing lens. That's a hard one. I'm not sure I'm giving great advice there, but it's in some ways it's more challenging because stable housing reduces risk in many ways, but.
Yeah, I think it's kind of tough that these are not mutually exclusive areas, and so you can address specific or needs specific to special and vulnerable populations, and simultaneously be enhancing your clinical issues. Or addressing some of the clinical or any of the other issues, finance, operations, everything. They're not mutually exclusive. They're all very much interrelated. That doesn't help you very much, but at least it felt good to say it. So.
Okay. Bob, do you want to ask your question about the key personnel that we should be targeting?
One thing I want to ask for first, though, and that is just within really any of the topics, and Allie touched on some of the issues that were important to her, and I'm sure most of us earlier. But are there any topics within topics, around finance? I mean, of course, like reimbursement, whatever, that are really paramount. And even I know that the program requirement stuff, has been in place now for a year. But is that something that we should address? Is there anything specific to SDOH, other social determinant issues that folks want to really focus on addressing? Whether it's maybe aside from housing, I mean, education or enabling services or something within that. So is there anything that's really, really jumps up at you and says, boy, I've really been looking for an answer on this, or I have a great idea on this, and I'd really like to, I think you guys need to address it, or we need to address it, collectively at the, at the conference. I guess.
Well, I believe that it's important to let the group know that there will be some focus groups, that these are broad topics, as is been mentioned, but we are working with the other 20 NCAs and some primary care association just to better define what are the issues within these issues. So if I'm not mistaken,
between now and June 30th.
Between now and June 30th, probably next conference call, we will have additional information.
Is anybody on the phone by any chance participating in any of the focus groups? Has anybody received a call from NORC or NAC or anybody to participate?
No,
Nobody?
I have not.
Not me, no.
Okay, I think we should follow up with it because we've actually probably suggested just about everybody on the phone. So I'm a little curious as to what's going on. So we need to follow up with them. Okay.
The other thing that I believe is important, since we've been talking about chronic medical conditions, as you know, diabetes has been HRSA's initiative, but public housing residents and low-income populations in general have different kind of health needs. So one of the questions that probably I have for the group is, when we offer any training like a webinar or an activity, how is the best way to communicate the training activity to your staff? Because sometimes the activities that we do probably is not for the CEO or the COO or the CFO, but probably community health workers may be interested, doctors may be interested, nurses may be interested, and we do not have I believe, vehicle to communicate with them.
Right.
So how in your case, is it always best, I guess, to send the information to you and then you can forward it to them, or what is the best way to communicate with the other staff members?
Yeah, I mean, and we've had recent experience where when we target a specific, labor category, we target the chief medical officer, or we target the information technology person, we get a much better result. And we're trying to, I understand what the channel of communication is in each of the health centers, because it makes a big difference. Because right now in UDS, we get the board chair, we get this, the chief medical officer, and we get the CEO, but we really don't get the other folks. And sometimes it's the other folks that the training or the publication or whatever, the technical assistance is most relevant to. And we're just trying to find the best way to reach those folks. And also to think about, for example, for a conference, or a webinar or whatever it is, who is the audience going to be, and how do we make sure we get the right people in the audience, or on the flip side, that we get the right types of information or type of information to those folks. Whether it's issues on value-based healthcare or clinical quality or workforce or finance or case management or patient engagement or partnership building, all of the above. So back to kind of Jose's point, is it best for us to reach to you guys, or should we request kind of additional contact information on some of these specific clinical or management staff? Veronica?
Yes.
Do you have any thoughts on that question?
Oh,
on that
no,
issue?
I didn't hear you. I just heard a blank. Everything just went blank, and I was holding on because I'm like, did they all hang up?
Oh my goodness. Okay.
I thought we got disconnected.
Okay. I apologize. Did you hear Jose? Jose's. We were basically just looking out. We're looking to find out how to reach and how to tailor what we're offering in training and technical assistance to specific labor categories and so on. And the labor categories we have, for example, through UDS. And so when we do, a mailing or messages or whatever, we have the board chair is in UDS, the CEO is in UDS, and the chief medical officer is in UDS. But we know there are a whole bunch of other important people out there. There are people dealing with partnership building and people dealing with patient engagement and case management. We have various levels of clinical staff. I mean, you have, the chief medical officer, but you also have, care coordinators. You have social workers, people doing various aspects of behavioral health. We have people who are dealing with, more, capital improvements and facilities issues in some cases. And we have a lot of concern, a lot of big issues around data, using data, managing data, collecting data. So I guess we're trying to figure out, if in terms of, getting feedback and disseminating information, a lot of the stuff ends up going through, CEOs. And should that continue, or should we do that in addition to some of the other, leadership folks, at the health center? And if so, which ones beyond the ones that we find in UDS?
For me, I think it depends, because when I get everything I get, I forward it to the appropriate people or just include it to my my leadership team. So if you're going to get it to others, then you'd have to send out an email to all the CEOs and say, who else in your organization would you like us to put on this list?
Yeah.
Mm-hmm.
Yeah.
Like development, it could be development folks, finance, and as you say, director of quality people.
Mm-hmm. Yep. Yeah, because I mean, we have the CMO's information, but in a lot of cases, it's the quality manager who is sometimes the key person for some of the stuff we're doing. Even Jose's like clinical quality working group. I think in that we usually have the CMO and the quality manager. And so when we're reaching out, right now we have good CMO information from all health centers, but we don't have great information for all the quality managers in all health centers.
And we need to get those people on the list.
Yeah.
Mm-hmm.
Yeah.
Mm-hmm.
Any other labor categories that folks think we should definitely include? And is there anybody who thinks no, we should just send all this stuff through me? Or do you want to be copied on everything, or how would you like that to go? No? I'm not sure if people are getting it or if people are just running out of time. No. Okay. All right. I think what we'll do then is we're gonna go out and we'll send something out, and maybe we'll put a variety of labor categories on there and then give people another choice. And the only question for the folks here is when we send stuff out, I would assume you would like us to still copy you on it. Even if it's going to a specific professional, or is that just too much material coming at you?
Yeah, I mean, I trust your judgment. I don't feel the need to be copied on everything. It's if you feel the need to send it to me, send it to me. If you feel the need to not send it to me, don't do it. I'll trust your judgment.
Okay. Anybody else?
I agree.
Okay.
I agree. This is Veronica.
Okay.
Excellent.
Bob, I hate to cut out, man, but I got to go. So
no, I got you. Okay. Saki, do you have any more?
No, that's it. Thank you so much.
All right.
Oh, one last question, and this is just a quick thing, because it's come up recently. How many folks on the phone is there anybody on the phone who is using telehealth as part of their regular delivery of health care?
This is Elise. We haven't started yet, but we're going through the process.
Okay. Anybody else? Allie?
This is Veronica. We haven't started yet, but I'm looking into it. I'm looking to start it.
Okay. How about Henry or Allie? No? Okay. All right, just check. Well, thanks very much. All right, guys. Well, thanks very much for taking the time today. Much appreciated. We will get back to you on the issues, and we'll plan to talk again in 2 months. Have a great day. And again, thanks very much.
Thank you. You too.
Thank you.
Take care. Bye.
Thank you.
Thank you. Have a nice day. Bye.
Thank you. Bye.
Yeah, I think we need to make this a little